settle into the room. Please feel free to introduce yourselves to each other in the chat box. We'll be sharing maybe some links. You have an opportunity to put questions in the chat box, comments, personal greetings, introductions. So we have a big group here today. Great, welcome. I see people are introducing themselves. Fabulous. Melissa from Boston. I know you. Okay. Well, hello everyone, and welcome to the webinar on peer support workers in crisis service programs. We're talking about 988 rollout and more, and I'm joined by my colleague, Wendy White-Tygreen. She will introduce herself as she presents, so welcome. This webinar is sponsored by the Opioid Response Network. Many of you have heard of it to date, but if not, just understand that the Opioid Response Network is available to you to get training or technical assistance to implement evidence-based treatment, prevention, and recovery programs. They'll do training for you virtually, come to your place of employment and do kind of some consultation. So they're accepting requests for education and training. They do a lot of training on peer support services. And so that is a topic area that you can reach out to them for. We'll have specific links to reach out to perhaps SAMHSA for more information on 988 rollout itself. But this is how you contact the Opioid Response Network. And we are funded by SAMHSA. And today we are going to start by talking about the crisis care continuum. Looking at, people talk about 988 rollout as if it's a phone line, when in fact it's an entire system of crisis services and care. We'll look at the role of peer support within the services, some of the organizational needs as programs are shifting and changing and employing more peer support workers. And then thankfully we have Wendy with us today to talk more about funding and system level resource needs. I think we'll do the first poll now to see who's in the room. We know that there are well over 100 participants in the room. So we just want to know who you are. If you don't mind, please just click on kind of what best describes you. You can check all that apply. So we'll total over 100. Okay, so go ahead and answer the poll question. Can you all see that? Yes. Hosts and panelists can't vote. Okay. Melissa, how are we doing with the poll?
We've got a few people still responding.
Okay.
So I think I'll give it a sec. When we get to 75%, let's post it for everyone.
That's a good outcome for a survey. Okay. We have a lot of peer specialists in the room. About a third of us identify as that. Yep. A person served, 17%. A lot of advocates in the room as well. It's important that many of us put that hat on in addition to our other role within the system. Some clinical administrators, program directors, a couple people from policy, finance, that's fabulous, and clinical providers. Great, thank you so much. So I'm going to turn things over to Wendy, who's going to kind of introduce us to the kind of the system of crisis care. And Wendy, you can introduce yourself, please.
So good afternoon, everyone, or I guess for a few of you could be further out on the West Coast. And so good day to everyone. I'm so glad to be here with you. And I am I'm assisting during this presentation today, working with C4 on this initiative. But on a day-to-day basis, I'm actually a policy and finance administrator for the state of Georgia, the Department of Behavioral Health and Developmental Disabilities in that state. And I just think it's probably important for you to know, people know Georgia as a peer support leader around the country, but I have the wonderful benefit of having been the original negotiator with Medicaid in 1999 for the creation of really what became the launch of formalized peer support around the country. And so I've been doing this for a really long time, and I have a great passion for this work and for the value of lived experience. I am also one of the 3 leaders in the state of Georgia who is overseeing the 988 implementation. So my role isn't overseeing peer support in Georgia. My role as an administrator is to kind of lead the charge on major healthcare initiatives, and this is a major healthcare initiative. And so with that, I'm going to begin the content here and help us start to learn more and more about the 988 overview. And as Cheryl so aptly described, this is really about the implementation of a crisis services continuum for behavioral health. So while 988 is a numerical number that you can dial, the intent of law, which we're going to talk about in just a moment, is really about creating a services infrastructure so folks can have the opportunity to receive services when it's the most critical and the most crucial. So the national law that has been rolled out, the US Congress has set forth this in motion. And the law really talks about several elements, but SAMHSA has kind of aptly put it into 3 major buckets, as I will describe them. So there needs to be someone to talk to, someone to go, and somewhere to go when there is a behavioral health crisis. And many of us are aware right now, either there's a sense there's nowhere to go, or folks end up in places where it's not the most appropriate setting for support. So maybe an emergency department where there are many healthcare experts, but maybe not behavioral healthcare specialists, or in places where law enforcement is becoming involved or emergency medical services are becoming involved. So really, this is a national push to have the right services available at the right time and in the right way. So these 3 buckets, I'm going to just tackle each one of them quickly to get some kind of sense, give you some kind of sense about these categories. So someone to talk to, is there available 24 hours, 7 days a week, someone to call, text, or chat about a behavioral health crisis? And that is inclusive of concepts of peer run warm lines, which may offer callers emotional support. They could be staffed by volunteers or even paid peer specialists who are in recovery themselves. The someone to go, that is really like the deployment of assistance to the community where the person is at, experiencing their crisis. So is there mobile crisis response available statewide? So can someone respond when you're in crisis and you're in your home or on the place of work or at maybe a school? Any of the places and communities where people exist and breathe and live that is not in a medical setting. That requires coordination with 911 and emergency medical as appropriate, right? That's not always necessary, but sometimes it could be appropriate to have those partnerships. And then having outpatient community provider response. So a local community mental health center or a peer services provider, those folks could also be kind of part of this mix in the response for someone to go. And then somewhere to go, really, is there a type of space that is behavioral health specialized that can be available on an emergent and urgent basis? So like a crisis stabilization unit, which is kind of globally defined as a place that's available 24/7 to present to, you can be evaluated, and then perhaps you stay for a residential, really short-term residential length of stay. We'll talk about these more, and provide and receive some crisis intervention. A crisis service center, which can be like a walk-in 24/7, no appointment needed type of facility to receive some behavioral health quick intervention. There are models of peer crisis respite, like a living room model. And again, we're going to talk about these. Detox and substance use disorder treatment. There could be really somewhere to go is also representative of inpatient beds, although we hope that's kind of the last alternative. And of course, then there's outpatient crisis services as well. So next slide. So recovery matters, folks. Like recovery really matters. So in all of the buckets that I was mentioning, it really is crucial to be talking about peer support as being an integrated part of all of these response types. And that's because recovery is so crucial to health and wellness outcomes in that moment of crisis, post that moment of crisis, and then in terms of sustaining real recovery and wellness post a crisis event, when you're just really trying to work towards your health and wellness and stabilization for the future. Next slide. So this is like one way to be thinking about those three buckets, but to be thinking about the ways that we have to bring some real principles to this work. So in the past couple of slides, I talked about first, like what do these buckets look like, right? Two, then what is kind of an overarching principle, like recovery matters, right? But then really between those two things are some really important principles that we all need to be thinking about that cross all of these ways of providing crisis support. So for instance, are all of these responses culturally and linguistically competent and equity focused? Is there, I'm just going to hit a couple of these, is there special population focus, particularly for like LGBTQ populations, veterans populations, deaf populations? Like what are the ways that we really have to think about this for all the individuals that are maybe in need of support? Do we have technology? Do we have like leadership and oversight that really can oversee and push the development of these services? Is it clinically effective? So all of these things, but the two I want to focus on, you see a little bracket beside while we're going to be talking today. Is there competent and supported workforce? And right now we have a behavioral health workforce crisis in the majority of the country. But particularly, it's going to be necessary and crucial and important if we are to hit the mark on Recovery Matters, right, to have certified peer specialist, and that's a Georgia term. I'm using the term and the acronym that Georgia uses the most. Certified peer specialist may be called something different in your state, your locality, but very important to have the peer professional lived experience practitioners in all of this. And two, do the services delivered by anybody, the physician, a licensed social worker, nurses, parapros, call responders. Does everybody have a recovery orientation basis and a good way of thinking about recovery in order for this really to be the most efficient and effective model of service response? Next slide. So, and then there's like these core principles too, right, of crisis service systems. So I mean, I was talking about the buckets earlier and some principles, but again, just thinking about here, just crisis service systems in general. So embracing recovery, right? You're hearing this now consistently from me. A significant role for peer specialists, trauma informed. So are folks really trained on trauma informed principles? Are we really considering suicide safer care? So just being sure that we're doing intervention, which really, really reduces the potential for self-harm. Is there safety and security for the individuals that are providing the intervention, as well as those who are very importantly receiving the intervention? And do we have the right partnerships in play with law enforcement, as well as just like emergency medical folks as well, who may be in many cases the first responders on scene, or we need to engage them for safe backup to really resolve the crisis scenario. And so with that, I'm going to kick it back to Cheryl, and then we're going to go back and forth a little bit as we proceed. But I will turn it over at that point.
Thank you so much, Wendy. That was very clear. I'm going to focus more on the peer workforce here and potential roles within the crisis care system. Wendy mentioned several of the components, and I'm going to talk about, what is a role of a certified peer specialist or a peer recovery coach or a peer professional, peer practitioner in a crisis service line, access line, that be a hotline or a warm line, crisis stabilization units, mobile crisis supports. What do they do in crisis service centers? We'll talk a little bit about kind of peer-run organizations, peer-run wellness respites, and then talking about outpatient services for people who need more intense support. Kind of the thinking behind peer support within crisis services is based on the research on the best outcomes of peer support. Truly, peer support in several studies has been shown to do better than clinicians in engaging a particular population, very hard to reach. And that's often described as people who are extremely disadvantaged, maybe contending with multiple impairments. And peer workers have done a good job. A lot of people who may access crisis care services may be part of this group who have been hard to reach, hard to engage. The mental health system has not been successful in really kind of pulling them in for services. That individuals become more involved in their services, that it provides better outcomes in employment, housing, more satisfaction in provider relationships kind of across the board. There are some outcomes around improved quality of life. There were several studies that demonstrated participation in peer support led to improvements in quality of life. And then in the youth system, in the family support, increased child welfare reunification. Decreasing substance use disorder, decreasing emergency department visits. And that's a really big goal of of the whole 988 response is, to use emergency rooms, for medical emergencies and attending to mental health crises or other crises in different environments. Reducing inpatient days. We do know that people with serious mental illness prefer not to use hospitals, so decreasing inpatient days is good. Reincarceration, rehospitalization. And we also know that it is a cost-effective service. So these data are still coming forward. But the other piece for, in talking about suicide safer care, peer support is the one intervention that really attends to two of the main issues with, for people with high levels of suicidal ideation. One is this kind of thwarted sense of belonging, right? Not belonging, disconnected from the world. And peer support's main mission is connection, right? That's its primary mission, is to engage and connect. So it addresses that. The other thing with suicidality are incredible levels of hopelessness and despair, in addition to the disconnection. And again, peer support is sort of deliberately, intentionally, engaging people to find reasons for hope in their lives. So those are two other things. Research hasn't picked it up, but those are important outcomes. So if we talk about call crisis centers, and I do have a couple resources at the bottom of this slide. Again, they are required to operate 24 hours a day, 7 days a week, every day of the year. They do provide clinical oversight of triage, and most everyone will do a suicide risk assessment. They do facilitate connection or contact with mobile crisis if necessary, and connect to outpatient services with a warm handoff. So it's not just getting someone off the phone, talking them off the ledge, so to speak, but really having them sit down and try to prioritize some goals and needs, and organizing services to respond to that immediate crisis. Some call lines, hotlines are integrated with a call center having both a peer support kind of warm line response in addition to a crisis hotline. Many of the crises, when we look at crises, do have to do, with issues that are not especially hot. We'll talk about that. It might be sort of a chronic kind of worry that really brings a person to despair. But hotlines are usually connected with crisis and suicide prevention. They do include screening and assessment. And so, peer support workers don't do assessments, right? Formal assessments. And so wouldn't work on a hotline, but could have, a response on a warm line. They typically do include emergency interventions, 911. But typically they don't work with people either before or after the crisis, right? Their job is to really triage the crisis and link the person to services that are going to be most helpful. Whereas in peer support line, typically, often peers will work with people both pre and post crises. So maybe post-crisis to help them develop a crisis management plan for the next time, or an advanced directive, or a wellness recovery action plan to sort of maybe thinking about ongoing support. So warm lines have that flexibility of being able to meet with people both, before or after a crisis. They aren't a hotline, so they might use a voicemail and we'll get back to you. Kind of set up. They typically aren't funded to be 24/7. There are some examples of fully integrated lines. I know the Rocky Mountain Crisis Partners in Connecticut is a great example of an integrated peer and clinical line. And so take a look at them. So again, hot topics, warm topics. A lot of calls that come into crisis lines may deal with warmer topics, things like existential and spiritual crises that may grow intense, as the dark approaches. Navigating services and systems, like people who are really frustrated. I can't get an appointment. I have no medication, certainly pre and post crisis. Leaving the hospital, we know that people are at higher risk for suicide in the weeks following a psychiatric hospitalization. It's one of the periods of higher risk. So off being able to kind of help people navigate that period of time. Whereas hot topics deal with, much more life-threatening suicide, homicide, and these other hot topics. So again, thinking about kind of the range of responses that, a crisis call center can provide. So call and response, there are increasing number of text or chat interfaces for people. I know, young people very much prefer communicating on text. They often have, highly formalized performance metrics. The goal really is to have a system. They even use the term kind of air traffic control to describe how high tech they would like the system to be in terms of connecting with a person in crisis, knowing, do I have at my fingertips information on where the mobile crisis team is, or is there an availability at the crisis stabilization unit? Would that be a worthwhile plan? So having real-time information. So that's the goal of really of developing a very technologically advanced kind of hub to help the whole community, help people who are experiencing crises. So again, different flavor to the warm line, a lot of chat and options, very much recovery focused. There may be, some training of certainly of how and when to make a referral to something, to a clinical line. And that happens that somebody, is working with someone on the warm line, and together they'll decide to, consult more clinical expertise. So helping someone who is on a warm line become connected to hotline if necessary. So mobile crisis teams, there are people with peer support specialists working as team members on a mobile crisis team, usually responds to urgently to someone in a behavioral health crisis. Typically the performance, is within 59 minutes to come in under an hour. Teams typically are at least 2-person teams, like people don't go in it alone. A person recognized by the state as a clinician. So that could be, a social worker or an certified addiction specialist, licensed mental health counselor, and often are paired with a peer support specialist, a team. And many states have implemented this model and are, attempting to really scale this model across their states. So again, conductivity to the crisis call service, telehealth for supervision or specialist engagement. If you need a physician to do a rapid assessment of something, telehealth is available. So in addition to the expertise of the two, the clinician and the peer support specialist, there's access to additional help, and often partnerships with emergency responders. This is the service that may partner with law enforcement depending on the safety issues within the crisis. The goals really are to de-escalate situations before, police response is needed, relieve the immediate distress of the individual who's experiencing crisis, Sometimes, mobile crisis teams are able to do that, and, there's no ongoing, service needed at this time. Other times, mobile crisis teams may help somebody or transport somebody to a crisis stabilization unit. But it does reduce the risk of individuals in crisis situations doing harm to themselves or others. It also reduces the risk of police violence and, incarceration. So mobile crisis teams have a real kind of harm reduction approach to connecting with people in crisis, and really work to promote kind of timely access to ongoing services. So that I've talked about mobile crisis teams again in many of your home states. That's really coming to scale. I look at the job announcements. There are a lot of team members for mobile crisis at this time being recruited. Crisis stabilization units are typically located, they're sometimes in a freestanding clinic, but it's it's a crisis setting for behavioral health. There is a team of professionals, including physicians, psychiatrists, nurses, social workers, counselors, peer specialists, other paraprofessionals and specialists. Crisis stabilization units do have the capacity, depending on the jurisdiction, to take involuntary admissions. So that is still a reality in crisis care. Can be highly partnered with law enforcement, can prescribe and administer stabilizing medication, and is by definition very short in duration, a couple of days, and maybe fewer, to try to as long as like doing triage and being able to assess what does this person need next. It may be going back home with additional recovery supports in place, home visits, home health aid visits, or it could be, moving on to a treatment in a more specialized clinic, like a drug and alcohol treatment program. And so the goal is really to have it short-term triage, again, using real-time information and helping people get to the best fit service for them. A living room, is a model of crisis stabilization. It's a place that looks and feels more like a home than a clinic or a hospital. And I do have to say, they really made attempts with the stabilization units to make them look a little bit less like a hospital emergency room. You'll see if you kind of Google images, a little bit more comfy than you expect in a typical kind of hospital emergency room. So a place that feels, natural, has a friendly, accepting environment. People offer you a cup of tea, right? Sit down with you and talk. Non-judgmental restraint, long non-judgmental acceptance, and a policy of not using restraint and seclusion. A lot of peer support in this, and often they are attached to a crisis stabilization unit, and so people could, may select to come to the living room or be clinically assessed as being safe in the living room. A normal mode of transportation, you don't see people coming in change. Crisis stabilization services are certainly in the ER, and lots of involvement with law enforcement can be very traumatizing. And I think the living room really tries to create a safe, cozy environment where, fewer sort of trauma triggers are going to come into the space. So that's that. And then there's peer respite services, and these are peer run by peer support organizations, totally voluntary. Again, short term, and to be short term, they're not going to solve the housing crisis in this country, but that provides very community-based, non-clinical crisis support to people who are really having, really wanting and needing to learn new ways to move forward. It does operate 24 hours a day, cozy home-like bedrooms, private bedrooms. Peer respites are staffed entirely by people who either have a behavioral health condition or have experienced trauma or extreme states of consciousness. And so some are affiliated with more formal behavioral health system organizations. Others are, are freestanding. One of the challenges with peer respite is there are too few to go around, and there's always a waiting list. Crisis prevention, I do want to talk about the peer role in crisis prevention. That's the best crisis is the one that's prevented, right? And good services and supports to people who are engaged in, helpful relationships is a great way to reduce the number of crises that are happening. And so structuring, peer support programs that help people transition, people who are leaving hospitals or leaving prisons, that's a really high time for a lot of risk for crisis. Crisis prevention plans, working, collaboratively to develop something that might work for the person. Ongoing peer support. There is a group called Alternatives to Suicide, which is a support group for people who have suicidal ideation often and want a safe place to be able to talk about it. Kind of similar to, I don't know if anyone's gone to Hearing Voices Network, which is for folks who hear voices. Some of them who have, psychotic disorders and hear voices. Others are just people who hear voices. But there's a network of support for people who hear voices. This is a similar thing, but just really starting to get off the ground here in the US. Most people know about WRAP, the Wellness Recovery Action Plan, but working with somebody on a WRAP is a powerful way to kind of reduce risk of crisis, providing, enhanced support. And then a lot of the harm reduction practices of offering people, either some educational tips, but more likely some resources they might need just to reduce the harm that they may be in. So I'm going to turn it over. That was rapid, but I'm going to turn it back to Wendy because she's going to talk us through some of the experiences in Georgia.
Thanks, Cheryl. And that was kind of a great foundation of then what now I'm going to be sharing some more of. So again, like you think about what Cheryl's talking about, and then you think about like 988 implementation really globally. I'm just going to kind of provide you with some frameworks for thinking about this that are real in our state. And so you see kind of what I'm talking about, the emerging crisis system, peer supported, right? So in almost all of these scenarios in Georgia, we are allowing and promoting peer specialists working in these spaces and places. And I was responding to some of you in the chat as Cheryl was talking, fielding some questions about that or providing some extra context to some of these things related to peer work and recovery. So in Georgia, we're going back to the buckets, right? You see the little icons now that you've gotten used to on the Somewhere to Call line. We have a Georgia Crisis and Access line. And Crisis and Access line for us is not just the crisis response, but it's also sometimes warm calls, text chats, very much like Cheryl was articulating about needing some engagement and just needing to connect with someone. So we call it also this access line. And in Georgia, it is connected to the entirety of the behavioral health and Medicaid provider networks in order to make referrals and access. So, you live in this zip code or you live in this county. Can we tell you about this provider you can go see? So in Georgia, it's like what people are talking about related to the emerging call center functioning, but with some bonus content, right, of the access line. So that's in the blue box. And it's kind of like what we call a preferred point of entry for the system. It's not a mandatory. You can kind of touch any of these green boxes you see here through other ways, but really we talk about this as being a preferred point of entry for engagement to the system as a whole. But we also know that there's other ways to have, a call response. So there's just call responses that could be, through other call lines, through United Way call lines, right? But they're not going to be connected as much to the system. And then you see on the right side, provider responses. So if you are currently going to a community mental health center, you may then very well need to call the mental health center first, who knows you, who has your recovery plan on record, where you have your supporting clinicians already. You may call your provider first, and all that's okay. But again, in Georgia, moving from that first line to the second, the somewhere to go bucket, with urgency, you see the blue box directly up underneath the Georgia Crisis and Access line. So if you call the line and you are in a critical situation and need deployment of a mobile crisis team, as Cheryl and I were describing, the Georgia Crisis and Access line actually then deploys mobile crisis. So we're connected. They have apps that literally can contact our two contracted vendors and deploy them based on location that has been provided by the individual caller or by the caller's family or natural supporters, and mobile crisis can respond. If we have some pretty decent information from the Georgia Crisis and Access line, and for instance, we know it happens to be a substance use crisis versus a mental health or psychiatric crisis versus, for instance, like an autism crisis, we can deploy the different types of specialists. And even better, if it's possible, we can deploy the certain type of lived experience practitioners to go with. So for instance, as a child and family, we might be able to deploy a peer specialist parent or a peer specialist youth on that team. And peer specialist youth in Georgia they're over 18, they're 18 and over, but they've had lived experience as a youth with behavioral health conditions. So we can kind of work on that team deployment based on what we know from a triage from the Georgia Crisis and Access line. 911 may also be deployed, right? So we are hopeful that we don't have to do active rescues, but in some cases we might have to call 911. And hopefully we can call a 911 that maybe has a co-responder model locally, where we can have a practitioner being in accompaniment, or 911 can go with our mobile crisis teams. They actually can meet up and go together. So you have potentially a peer specialist and a licensed practitioner, and they're meeting with the 911 support in order to de-escalate the crisis as safely as possible. Again, we're not going to 911 all the time. It's really when there's a need for a very rapid active rescue for an individual when we use that partnership. And we're so grateful to those leaders who help us significantly. But then there's also someone to go. In Georgia, we have a service called Out of Clinic Crisis. And we pay a little bit more money by unit for our community mental health centers and all of those enrolled providers to do crisis intervention in communities. So if they know you and you're one of the people that they serve on a regular basis, we also strongly encourage through a payment mechanism that allows for that travel employment for our providers to do this as well. And then finally, somewhere to go, right? We have crisis stabilization units in Georgia, which are really just what Cheryl and I were describing earlier, really kind of high acuity, multidisciplinary team staff with an overnight capacity to do rapid stabilization. We have what are called behavioral health crisis centers, which are 24/7 outpatient centers. And again, we only have less than 20 of those around the state, so not nearly enough, but 24/7 walk-in capacity for outpatient, where we also require that certified peer specialists are part of that multidisciplinary team on every shift. And then, of course, there's inpatient alternatives. So while we try not to really use state hospitals with any frequency anymore in Georgia, we do know that there are times where you need acute psychiatric stabilization or even, like detoxification levels of care. And so there are some of those inpatient alternatives that we can refer to. Again, the Georgia Crisis and Access Line has all of that information, at least for Medicaid and for the public system in their system, to make referrals and try to route people through a bed registry process to the best inpatient alternative possible if there happens to emerge a need for that level of acuity. But then what I want to also highlight here is this other line below the blue. Like the 988 law talks about everything above that bold navy line, but really what we have to be focusing on is some community-based outpatient services for all that prevention work that Cheryl was talking about, as well as some recovery-oriented supports like peer support and psychiatric rehabilitation and some addictive disease skills services, to be sure that there's really some recovery support in play for individuals, which can help them have their own recovery plan, to have them have their own wrap plans and the like. So next slide. So again, I think it's just a little bit helpful to see how robust the peer-specific services are in Georgia. And I want to lean in and hope that all of us are getting to this kind of space across the country. So in Georgia, all the services you see in the Navy circle are a statewide benefit in Georgia. So while they may not be in every little small community, we have enabled them and enacted them to be available across the state. And so you see the variety of types of peer-specific services. And then you can see, and it's subtle, right? But that pale gray is a non-Medicaid benefit. And all the ones in the more bright white color are actually Medicaid covered services benefits in Georgia. So we have addictive disease peer support. We have mental health peer support, one-on-one and in group. We have parent peer support. We have youth peer support. We have peer support, whole health and wellness. But we also have these health and wellness centers, very similar to the respite models that Cheryl was describing. We have a lot of recovery community center services. We have peer mentors in our state hospitals who assist with transition. And we have peer warm lines for both mental health and substance use, lived experience warm support. And then we have all these little target initiatives across the bottom, right? We're still always learning. So trying to roll out a small pocket of learning and leadership over in a small space so that we can continue to learn how we might adopt bigger and more global projects up in the Navy circle, hopefully in the future. And then next slide. And then this is other spaces, other services then in this green circle that are peer enabled or peer engaged. So for instance, I'll take a really easy example on the right side of the green oval, assertive community treatment. So for Georgia, our assertive community treatment team requires a certified peer specialist to be a member of the team. Our crisis stabilization programs, peer specialists are required team members in that model. So family training, we have certified peer specialists who can deliver that. Psych rehab, peer specialists can deliver that. So you go all the way around and you can see all the ways that Georgia is really trying to enable certified peer specialists to be a deliverer of even services that aren't defined as traditional peer support, Because if they can infuse hope and recovery as they deliver customized care coordination, well, more the bonus, right? So again, we create a lot of niche content for certified peer specialists, but we also recognize the voice of hope and resilience that are critical and try to infuse that into all the services that Georgia does. Next slide. So Georgia also does kind of a lot peripherally to nurture this guild. And I'm really intentional about the use of the word guild. So I'm a social worker, and we have like a national association, and we kind of all understand what our roles are. This guild is crucial to the behavioral health services system, and we need to be working with the workforce in considering all of these things here. So how do you do like some recruitment in pre-academies? What is the policy that supports all of this work? How do you define the roles of peer specialists in all of these services, 988 and more? What is the financing and reimbursement, not just for the providers, but also the salaries, benefit structures, and the like for peer specialists? How can we provide training? How is supervision offered? What are the soft skills trainings that are needed for folks to really be strong members of the behavioral health system infrastructure? Continuing ed. And then I just want to hover here for 1 second. Crisis-centered support is going to be crucial. Crisis service delivery is tough for any practitioner, for docs, for nurses. Just go into an emergency department and ask one of the employees there. These are tough environments, not just specific to behavioral health. Crisis intervention is hard work. So how do we support the peer workforce while they are emerging as a crucial guild and workforce within like this 988 infrastructure? Next slide. Okay, so then on financing, we have to like think about a lot of things related to how this whole 988 infrastructure gets funded in the future. And in every local jurisdiction, wherever you're sitting, whether or not it's a county or a municipality or a whole state coming up with a game plan for this, you have to think about a variety of funding. We're not going to spend too much time on this, but the 988 law that Congress passed allows telecommunication fees, and each state is contemplating how that might get assessed on local cell phone bills. So be listening for that in your states and your municipalities and counties to try to figure out what's going on with that. How do you advocate for that? How do you better understand that? States are coming up with appropriations for some of this work. Medicaid is releasing different content, and you can use different mechanisms for Medicaid for some of this work. Medicare and private insurance, they're a little slower on the draw, folks. So we're going to have to be listening and nudging and advocating for how Medicare and private insurance will not just recognize crisis services, but will recognize peer support specialists providing this service in particular, because really neither of those major payer types have really done a good job yet figuring out how to reimburse peer support, much less peer support within these crisis models that they also don't reimburse. And so we're going to all have to be about the advocacy for that. Next slide. So the one thing I do want to just kind of underscore here is that there's a lot of risks and a lot of opportunities in this 988 implementation, and particularly as we're talking about peer support. So recovery, infusion, hope, right? Those are like awesome things that the peer workforce can bring to this body of work. But I also just want to say that role clarity and providing the service in a crisis modality, those are things that are really tough, right? When you're on a crisis team, and you're deployed in the field, how does your partner responder understand your role? Like it shouldn't be trivialized in any kind of way. And there's risk there, right? So if you have a licensed practitioner who feels like in some ways, well, I've got to do this and I've got to do that, and I might have to do a commitment order and call 911 and kind of that clinical leadership, you don't want the peer specialist role to be diminished in that. There are unique roles and unique gifts that are brought to bear. And so you don't want in a party of two for things to get awkward like this. So how do you assert the role of recovery and lived experience while in these really challenged scenarios that could be kind of, every single one of them will be unique every time a mobile crisis team is deployed. And it's also going to be the same thing in crisis stabilization units. So those are some risks that we're all going to have to address. Excuse me. So next slide, which is questions. So I see some here we've been answering, but Cheryl and I are happy to entertain briefly any answers to some of your questions.
You are all on mute, so you'll have to put questions in the chat box. Crisis peers have a caseload. The question is, will crisis peers have a caseload, or will it be more like situational based? And I think, that may vary. In general, peer support doesn't talk about caseloads, but they may have people that they're, uniquely supporting. Depending on the structure of the peer program, that may make sense that, one peer may follow, a set number of people. But I think different programs have worked it out in different ways. Were there any other questions? Yeah. So I do want to remind you about, reaching out to ORN if you have additional training needs around peer support and, anything related to the opioid response. The other place to go is to look at SAMHSA's website. There are a couple anyway, of toolkits for states to start using or organizations to use to start structuring some of these programs. How could one access the WRAP program? That's a good question. I know they have a real visibility online. I don't know, Melissa, if you know the link off the top of your head. We can put that in there, but they're widely available online. And again, WRAP is Wellness Recovery Action Plan, which is a collaborative activity for people to really build a kind of wellness plan for themselves, similar to what Pat Deegan talks about as personal medicine. WRAP is proprietary, absolutely, but many states have really invested in having WRAP facilitators trained. There are certainly other kinds of wellness plans that may be available for no cost or lower cost. Thank you, Wendy.
Yeah,
there's the link to learn more.
Yeah, and it is personalized, and so you develop your own WRAP plan. It's not like a program you participate in. You just really craft your game plan for personal wellness, and it's more like a strategy. And so again, it's proprietary, as Cheryl was saying, but you can learn more about it here.
Yep.
Cheryl, there was a question from Paul about when the rollout occurs in July, who will be responding to the calls? Peers, clinicians?
I can probably take that one. The answer is it depends. And it really depends on the call center. So let me just say this, the 988 law is called the Suicide Lifeline Prevention Act. And so the Lifeline is the national call center. Then the Lifeline actually has 100 plus affiliate partnerships all over the country who are designated partners. And so then, like when I was talking about the Georgia Crisis and Access Line, if you call the Lifeline now and you have a Georgia area code, it rolls. The Lifeline number actually rolls to the Georgia Crisis and Access Line. In Georgia, we recognize certified peer specialists as well as other licensed practitioners as being part of the call response team. Now, certified peer specialists and other kind of care call consultants are trained in triage, and they can signal a clinician to sign into the same call to provide some really rapid fire clinical assessment if needed. So a lot of it's going to be jurisdictional, although the Lifeline is talking more and more about peer specialists being trained responders. So that's just a sense of what that will be. There's not a standard mandate.
Mhm.
There was
Okay.
one other question, if you saw that, about the length of time that peers in crisis usually follow a consumer that they're working with.
So it depends on the service. In a crisis stabilization unit, it may just be that 3 to 7 days. So it is quite rapid fire. So there's really a science to doing some rapid lived experience modeling and hope infusion fast. In a mobile crisis scenario, it may be an hour or 2 hours.
Mhm.
Now, we require in Georgia that our mobile crisis teams do follow-up post intervention, but it could be that you deploy and you quickly say, you need another level of care, a higher acuity. We need to get you to a safe place, right? There's somewhere to go. And so that peer, it may be just that brief hour to 2 hours, and then it's a moving on. So it's really a skill that everyone is going to have to develop about doing rapid engagement. And then in many cases, doing warm handoffs
Mhm.
or hot handoffs.
Mhm. Yeah. Well, thank you all very much. We're very pleased with the amount of interest in this topic. And I encourage you to learn more at the resources we provided and to join us again for another C4 webinar.
Thank you all. So glad you're with us today.